All right. Well, it's a pleasure today to introduce you to another grand round lecture with a visiting professor virtually. This is a new program that we have adopted in the last couple of rounds, given the restrictions on travel. And it is my privilege today to introduce you to the Transplant Institute lecture series at Henry Ford Hospital with our visiting professor, Dr. Alan Kirk. Dr. Kirk is known to many of you. He's currently the David Sabiston Distinguished Professor of Surgery at Duke University, where he's also the chair of the Department of Surgery and Surgeon-in-Chief at the Duke University Health System. Dr. Kirk has served as a past or immediate past editor-in-chief for the American Journal of Transplantation since 2010. He has expanded his content and scope and raising its impact factor to being one of the leading journals in transplant and in the surgical field. In addition to his transplant interests and transplant practice, Dr. Kirk is a national expert on immune management of transplant recipients. He has particular interest in therapies that influence T-cell co-stimulation with pathways and adjuvant therapies that facilitate co-stimulation blockade to prevent the rejection of transplanted organs without undue suppression of protective immunity. He's published over 300 scientific papers, manuscripts, and continues to be NIH, DOD, and FDA-sponsored investigator in organ transplantation and immune management. He has focused increasingly on the creation and analysis of multidimensional data for the use in real-world evidence, trial design, clinical decision support tool development, and drug discovery. Many of you know that Dr. Kirk has received his MD from Duke University, a Blue Devils fan, and he has also had his PhD in immunology from Duke in 1992, where he completed his general surgery residency as well in 95. He went on to the University of Wisconsin to have a transplant surgery fellowship in 97. He was with the U.S. Navy and reached the rank of commander and was a principal investigator in the Naval Medical Research Center. He has served as chief of transplantation at the transplant branch of the NIDDK till 2007, when he moved on to Emory University as a vice chair for surgical research and a transplant faculty professor. And since 2014, he has been in his current position at Duke University. He has received many honors, which include the David Sabiston Professorship, his Alumnus Award from Duke University, NIH Distinguished Clinical Research Scholar and Educator in Residence, and the NIH Clinical Center Bench to Bedside Award. It is my privilege to introduce you to Dr. Kirk, and the topic today will be intolerance. Dr. Kirk.
Thank you very much, Marwan. I really appreciate that kind introduction. First of all, let me make sure, can people hear me?
I can hear you well.
Okay, great. Then I will go ahead, and my screen is, I believe, shared. Can you see my screen?
We may have to share the screen again.
Yep, I'll do that again. All right.
Perfect.
Okay, so for a lot of reasons, I thought it would be reasonable to talk about tolerance today. Tolerance, of course, is what we call our ability to accept organs without the need for immunosuppression. But it has a lot of other meanings that are probably just as important these days. So you'll forgive me if we deviate in both directions. But for now, what I will discuss is tolerance as it relates to an intuitive approach to transplantation. And we'll begin with just a few comments on transplantation in general. The bottom line to transplantation is technically, it's not very challenging. Now, I don't mean to impugn the very talented surgeons who do this. I am myself a surgeon, but the techniques for transplantation have not changed dramatically in 100 years or so, being introduced by Alexis Carrel. And I think it is really interesting that our field goes back to someone like Alexis Carrel, because as we'll discuss, a lot of the views in transplantation are heavily reliant on previous views of our leaders. Alexis Carrel, as you know, was a French surgeon who was lauded as being the magician. This is a cover to a magazine in 1906 called the Chanticleer, where they portrayed Alexis Carrel as a contemporary magician being able to mix animals of all different sorts. But one of the important things that came from Alexis Carrel's work, not only that he was able to sew blood vessels together and combine organs from one individual to another, but he actually was able to observe for the very first time the fact that these organs would only work for a little period of time. And he coined the term rejection. It is interesting that he used that term, and we'll discuss it in just a little bit. But I'd like us to ask ourselves, what is rejection in basic terms? In fact, a better question might be, why is rejection? Why is there a need for us to reject other individuals and not ourselves? And that gets down to an existentialistic question of why do we exist? And in the most simple terms, in the most fundamental terms, we exist because of four fundamental forces in nature: gravity, electromagnetism, the strong quantum force, and the weak quantum force. Now, don't worry, this is not going to become a quantum physics lecture, but I think that it is important to recognize that although we, viewing the world through a transplant lens, think that rejection is a fait accompli, it is something that is hardwired into our biology. Indeed, all of the major forces in nature do not require rejection. In fact, they are all involved with the attraction of non-like things. Put simply, without going into much more detail, we exist because the fundamental forces that bring us together overcome the energy that tears us apart. And thus, although we think of organs as having to be rejected, that's really not the way the rest of the universe sees it. And that might be a good vantage point to start our discussion of why it is that we reject other people's organs, but we don't reject our own. Now, whenever I ask that question to a group of students, the first reply is always that we reject things that are foreign. And indeed, that was what was described by Alexis Carrel, that when there was something that was foreign, it had to be rejected. Now, the vantage point that Alexis Carrel had when he was making that up, because indeed that was just something he made up, is interestingly found in many of his contemporary writings. In particular, this one called Man the Unknown. If any of you have ever read Man the Unknown, you will be appalled by the political and social construct of Alexis Carrel. He might have been a very brilliant scientist, but he was not a very nice man. He was not a very tolerant individual. And his sense that there were extraordinary differences between the races of people that required rejection of an inferior race to a superior race is the origins of the term rejection in transplantation. Not a very good place to have the beginnings of our field. But let's ask the question in a little more scientific way. Do we have to reject things that are foreign? Is that something that is biologically mandated? Is immunity dichotomous in that you accept things that are self and you reject things that are foreign? So I'd like you all to do a small thought experiment on this right now. I want you to know or to think how many of your friends are products of a pregnancy. My guess is everyone you know. It's interesting to recognize that every one of you and everyone you know began as an allogeneic tumor inside of your mother. And the only reason you exist is because you were not rejected, despite the fact that you are most certainly foreign. In fact, once you come out of your mother, if we try to put an organ from you back in, it will be rejected. But the foreignness is not what drives that response. So without getting into deep scientific principle yet, just intuitively, you already know that we don't have to reject things that are foreign. In fact, our entire species depends on the fact that we do not reject allogeneic tumors until it's time. That brings up a common point that for every complex problem, there's a solution that is simple and neat, but unfortunately wrong. So let's start understanding why it is we reject organs if it's not because they're foreign. Well, one of the most important papers in this science was written by Peter Medawar back in 1953, where Peter Medawar did an experiment to see if it was necessary for animals to reject things that were foreign, and if it was, could they be trained not to reject foreign things? And he did an experiment where he took neonatal mice and he injected them with the cells of another strain of mouse, and then allowed them to be born and grow up, and then skin grafted them, and was able to demonstrate that if a mouse was exposed in utero or in neonatal times to cells from another strain, that when the mouse was grown up, it would spontaneously accept that other strain of mouse. Now, this is an extraordinary paper in a number of ways. First, Sir Peter Medawar, along with Leslie Brent and Dr. Billingham, won the Nobel Prize for what they called acquired tolerance. And they were the first group to use the word tolerance in describing this learned ability to accept an organ. Most people cite this article, but they don't read it. And it's a short article. It's just a few pages long. I would commend you all to read it because it shows some really interesting things. First of all, there were only 5 mice in the experiment. And of those 5 mice, only 2 of them didn't reject. So at its most fundamental point, this Nobel Prize was given based on the observations in just 2 mice. Another thing that he was able to demonstrate is that when he added steroids to the experiment, and many of you would say that steroids is something we give to almost every transplant patient, and it would make it better. In fact, steroids eliminated the effect, such that he showed that tolerance was possible, but showed that if you paralyzed the immune system, that it didn't work. And one of the last statements in this paper is an elegant one. And it's quite interesting because it relates to everything we've seen since. And that is that the conferment of tolerance is not an all or nothing character. Every degree is represented down to that which gives test grafts only a few days of grace. Meaning that when he did this experiment repeatedly, sometimes it would extend graft survival by a couple of days, sometimes by a couple of weeks or a couple of months, and rarely did it actually lead to lifelong tolerance as we would describe it. So intuitively, just as immunity is not dichotomous, tolerance is not dichotomous. It's not an all or nothing thing. It's a spectrum. And understanding that spectrum is really what our goal is in transplantation. And the next intuitive point is that tolerance requires action. If you paralyze the immune system, you paralyze not only the ability to reject, but you paralyze the ability to accept as well. And we don't typically see things that way. The other thing that I'd like to point out is just the use of the word tolerance. Tolerance, when you look it up in the dictionary, actually means the acceptance or endurance of pain or hardship. It is something about indulgence for something that conflicts with you or allows something that is a deviation from a standard. It's interesting that when Peter Medawar was coming up with a word, just like when Alexis Carrel was coming up with a word to describe what he had seen, Medawar chose a word suggesting that acceptance was wrong. It was a deviation, even though every pregnancy depended on it. Now, why is that? Well, it is interesting to put yourself back in Peter Medawar's time, which was right after the Second World War and during the beginning of the Cold War. And in fact, the political views of the time were driven by McCarthyism. It was very easy politically to state that foreign things were wrong and deviant and needed to be rejected, and that acceptance of foreign things required tolerance because foreign was wrong. Again, we often don't recognize that the political statements of our time influence our science. But every time you say the word rejection and tolerance, recognize that the word rejection came from an anti-Semite, and the word tolerance came from McCarthyism. Regardless, the fact that it was shown that organ transplants theoretically could exist very quickly led surgeons to start trying to do transplants. And just a year after Medawar's paper, Joe Murray performed the first successful kidney transplant amongst twins. And thereafter, demonstrating that transplantation was possible, we were off to the races. And we were off to the races with the understanding that rejection of an organ was driven by the immune system, and that paralysis of the immune system was the only way forward. And as you can see from this graph here, over the many decades that came, we kept adding more immunosuppressive drugs, and it kept reducing the risk of rejection and increasing the survival of our grafts, such that nowadays, when we think about somebody who is getting a transplant, we think of this, that they're going to have to take a lot of pills and a lot of medications to paralyze their immune system, because their immune system is dependent on rejecting things that are foreign. So let's go back to the basic biology and question whether rejection is necessary and whether tolerance is the right word for acceptance. So whenever you go back to an important question like that, you need to look at the fundamental components of that question. So what are the fundamental components of an immune response? Well, I would argue that an immune response is just a decision. Your immune system encounters things and then has to decide what to do with them. It's just another way of sensing your environment, just the way your neural system senses its environment and has to make decisions as to what to do. So how do you make a decision? Well, every decision requires some component of specificity. In other words, you have to be able to know what it is you see before you can make a decision about it. And then there is a component of context, that every decision has a contextual dependency to it, that you can recognize something but still not know the right thing to do until you understand the context of the question. And finally, every time you take action, there is a component of magnitude, that even if you make the right decision about the right thing in the right context, if you respond too weak or too strong, it'll still make for a bad decision. And molecularly, our immune system does this through 3 different pathways. A lymphocyte makes its determination of specificity through antigen receptors, a T cell receptor or a B cell receptor. And we call this signal 1. And then the context of the decision is made by co-stimulation and adhesion molecules. That when there's a lot of inflammation, there's a lot of expression of co-stimulatory molecules and adhesion molecules. And when there's not much inflammation or damage, those molecules are in lesser supply. And so it allows the immune system to know whether it's recognizing something new in an environment that is receptive or dangerous. And finally, the magnitude of the immune response is driven by external things like cytokines, and we call that signal 3, cytokine receptors and the like. Now, signal 1 is blocked by calcineurin inhibitors, things like cyclosporin and tacrolimus. It prevents the immune system from seeing anything. Signal 2 is blocked by co-stimulatory blockade molecules like belatacid. And signal 3 is blocked by things like mTOR inhibitors like rapamycin or cytokine blockers. And for completeness sake, mycophenolate mofetil also influences the magnitude of the immune response without influencing the specificity or the context. And so every time your immune system encounters something, it puts these 3 components of the decision together to decide how you're going to respond. It's like it was arranged in space, that there is a component of specificity, a component of context, and a component of magnitude, and that is what determines the right place for an immune response to everything you see. So let's talk first about specificity. Of course, specificity is something that we as transplanters know very well. And our field began with an understanding of specificity as it relates to histocompatibility testing. Paul Terasaki, of course, back in the 1960s, was one of the first people to teach us that the MHC of humans was one of the things that determined whether we recognized individuals as specific foreign individuals or not. And that gave rise to one of the most important tests of specificity that we know of. That's the cross-match. You know, the cross-match is so effective at detecting whether you have a specific immune response against another person that most of us will go through their entire life without ever seeing hyperacute rejection, solely because we have a test that allows us to predict whether that will occur or not, and it allows us to avoid situations where there might be hyperacute rejection. But importantly, this test set us up with a paradigm, and that is transplantation is limited by individual immune incompatibility that gives rise to an immune response, and that immune response can be measured. I think it's important to point out that way back in 1969, when this paper came out, we were already practicing personalized medicine. Personalized medicine is something that's talked about a lot now, but we've been talking about personalized medicine, recognizing the importance of specificity of our immune response for 50 years. Now, as those of you who are in transplantation know, the techniques for doing cross matches has changed dramatically. And I won't go into much detail about that, except for to say that we now are very aware that when you develop a donor-specific antibody against somebody else, that is clearly a issue that leads to worse graft failure. This paper by Peter Nickerson, I think, is one of the most elegant papers that demonstrates this. And so as we think about alloantibody determination and measurement as a means of understanding whether we've had a specific immune response to someone else, I think a few things are fair to say. First of all, that if you have a preformed donor-specific antibody, that's a clearly established risk factor for graft loss. It's better to avoid it than to have to mitigate it, but it's better to mitigate it than to ignore it. Second of all, if you develop a new antibody, a de novo antibody, that's also a clearly established risk factor for graft loss. And it's important to point out that that's indicative of an allo-specific T cell response. Although we know that antibodies come from B cells, it takes T cells to make an antibody response because MHC antibodies are T-dependent antigens. So it's indicative of ineffective T cell control. Modern immunosuppression, when it's used well, can prevent donor-specific antibody, but of course it has consequences. And the cost effectiveness of serially monitoring for DSA is probably underestimated because it really gives us situational awareness as to whether we're trying to form an immune response against a donor. There are a lot of antibody characteristics that we could discuss. I won't discuss them today just because of the limits of time, but in general, we underutilize the expertise of our HLA labs, and we should be looking at this much more. But it is also important to point out that antibodies detect an event that has already occurred, not one that will occur. If we're going to look for something that predates alloantibody, we have to move into the realm of T cells. And T cells determine specificity not by antibody, but by the T cell receptor. The T cell receptor is like a detector of a fingerprint, and the MHC molecule is like the fingerprint of the cell. And it is that binding of the T cell receptor to MHC that leads to the cascade of events that leads to an antibody response. So ideally, it would be great to have a test to determine whether your recipient had specificity for your donor. There are a couple of tests like that. One of them is called the ELISpot, and this is a nice paper from Peter Heger's lab that shows that you can detect allo-specific T cells. But the practical matter is that we don't have a test like the cross-match that works for T cells. So unfortunately, we can't do a test to avoid rejection the way we can do a test to avoid hyperacute rejection. Now, cells display their specificity through their antigen receptors before they respond. But unfortunately, as we have learned, almost every T cell has the capacity to be alloreactive against some other MHC molecule, either through heterologous immunity or something called thymic selection mismatch. I don't think we have time to go into the biology of this, but suffice it to say that somewhere in every person are T cells that can respond to every other person. That the ability to completely avoid a rejection response probably doesn't exist. So although we would like to be able to have a test that acts like a fingerprint to determine whether one person is going to reject another person, that biologically that just doesn't act up. But of course, intuitively, you already understand this. Just like biologically, everybody has the ability to reject everybody else. You can't really tell whether they will just solely by looking at the signal of specificity. Identity does not define intent. That you can definitely know that someone can do harm, but you don't know whether they will. So that brings me to context. If every person has the capacity to specifically recognize every other person, it's the context that determines whether they will or not. Now, to put this in a somewhat uncomfortable format, how we were influenced about detecting people coming into our country was changed not because different people came into our country, but because of the context in which our country established itself. In fact, it is the context that determines whether we are tolerant or whether we reject people based on their identity. Now, immunologically, the biology of this was also worked out many years ago by someone named Brecher and Cohn. These were immunologists that determined that B cell tolerance occurred based on changes in molecules that detected context, not by changes in molecules that detected specificity. And this was worked out for T cells by Kevin Lafferty. And indeed, many of the molecules of context were worked out by Polly Matzinger, an immunologist at the National Institutes of Health, who came up with what's called the danger theory of immunology. She posited that when you recognize something with your antigen receptors, you did not determine whether you were going to launch an attack or a retreat until you saw how much inflammation there was around. And so that suggested that you could shut immune responses off by targeting context instead of targeting specificity. And indeed, the very first papers that demonstrated that were in the transplant realm and co-stimulation blockade, one of the most important ones being this one by Chris Larson, where he took a couple of molecules that blocked the contextual signals of co-stimulation, CTLA-4 Ig and anti-CD154, and demonstrated that he could do heart transplants and skin transplants in mice with just a couple of days worth of context blockade at the time of transplant. And he also showed, just like Medawar, that when he added cyclosporin actually decreased the likelihood for tolerance. By paralyzing the ability to see the antigen, you prevented co-stimulation blockade from working. Now, this was about the time I was coming into transplantation as a scientist, and some of the first experiments we did were to take these context blockers into primates and then into humans to demonstrate that, in fact, you could lead to long-term kidney survival just with a couple of doses of these context blockers at the time of transplantation. Now, this is another paper that a lot of people cite, but very few people read. And if you read it, you'll find that not only did we show that we could prevent rejection for many, many months by blocking context, but we also showed that when you tested specificity, that all of the animals still maintain the ability to reject the donor. They were just choosing not to, such that their ability to specifically recognize the donor was not impaired. The context in which they recognized the donor was what was preventing rejection. Now, fast forward many years, and one of these context blockers, belatacet, came about. And in fact, that is now available for use as a calcineurin inhibitor alternative. And one of the things that we've known now over the last decade of using belatacet is that while belatacet can work, that the risk of rejection using belatacet in humans is much higher than the risk of rejection using cyclosporin. Now, let's think about that a little bit. If you use a drug that prevents your immune system from seeing the donor, they cannot reject the donor. If you use a drug that allows them to see the donor, but blocks the context in which they see the donor, that can be overwhelmed by a change in context. Now, we won't go deep into this paper just yet, except to say that cyclosporin and other signal 1 blockers are really good at blocking rejection, but they're also really good at blocking tolerance. And so that if we're going to move in this direction, we might have to understand that we're going to have to accept a coexistence with this rejection phenomenon if we're going to work well in that. And one of the reasons why this is less stable brings us to the issue of magnitude. Magnitude in transplantation is very different than magnitude based on viral immunity, the way our immune systems evolve. And I'll come back to the same analogy about whether we reject foreigners from our country based on their identity or based on their context. There's also an issue of magnitude. Accepting a single individual seems like it would be easy, but accepting all individuals might be very difficult. And in fact, the immune response to an allograft looks more like this picture than this picture. And the reason for that is that the allospecific T cell precursor frequency for alloreactive cells is multiple times higher than the response against virus. If you have a response against cytomegalovirus, cytomegalovirus is probably one of the viruses that we reject better than any other. And sometimes it can use almost 1 or 2% of your immune repertoire. But for allospecificity, over 10 and sometimes 20% of your repertoire can reject an alloantigen, such that even if we control specificity and control context, there are so many responders in an alloimmune response that sometimes that overwhelms the system and we can't make the right decisions. And so I'll ask one more physics-based question. We've talked about specificity, we've talked about context, we've talked about magnitude. Do these 3 points in space define the location of this object? Any of you who study physics will know the answer is no, because this object is also defined by its place in time. And the same is true for every antigen that we make a decision against, that our immune system is changing every day. Every time that we establish an immune response against a new antigen, we have naive cells that start dividing. Those naive cells kick out cells that have previously responded to other antigens to make room for this immune response. so that every time you respond to anything, you change the response to everything you've previously responded to. Now, how does this influence rejection? There was a great article published by Fatty demonstrating the importance of this, where he took a mouse and did a heart transplant in it, and he used mice that did not have lymphoid organs. They had lymphocytes, but they could not generate memory. And if you put a heart transplant and naive T cells into this mouse, the mouse will accept the heart. But if you expose the cells to a mouse that can reject, and then take those cells that have memory of rejection and put it into the same model, the mice reject right away, such that the specificity is not changed, the context of the transplant is not changed, the magnitude of the number of T cells has not changed. The only thing that has changed is the memory or the context in time. And it makes the difference between a complete success and a complete failure. So intuitively, tolerance is context dependent, and context is influenced by memory. Now, the characteristics of memory cells are things we're really starting to study quite a bit. And it's interesting to know, this is a paper written by one of my students, Denise Lowe, where she was able to show that when you develop T cell memory, you lose the expression of the molecule CD28, and CD28 is the molecule that belatacid blocks. And indeed, as you look at these memory cells, you can find other markers like PD1 that shows that these cells are becoming either exhausted memory cells or senescent memory cells. And if you follow people over time, you'll see that young people have a lot of naive cells. Old people don't have very many naive cells at all. Almost every cell in your body has already been used for something. And it is that memory that determines how easy it is to manipulate your immune system. One of these cells is a cell that expresses CD57. And I won't go deep into this paper except for to say that we have been able to demonstrate, and this is work done by Jacqueline Espinosa in my lab, that if you have a large number of cells expressing CD57, in particular CD4 cells, the chance of you having cells against which belatacid will not work is very high, and the risk of rejection against belatacid is very high. We've also been able to demonstrate in recent work that's now been submitted that if you have a lot of these co-stimulation resistant memory cells at the time of transplantation, and you're put on a signal 1 blocker, that even a year later, you still have a lot of these cells left. And that's because co-stimulation blockade is dependent on signal 1, and if you block signal 1, those cells can't change. There's a really nice paper that was published about 20 years ago that demonstrated this in mice, which basically showed that if you use a calcineurin inhibitor and you try to rid an animal of co-stimulation resistant cells, you can't do it. There are drugs that you can rid the body of co-stimulation resistant cells, but they're not calcineurin inhibitors, they're mTOR inhibitors. They block signal 3. So if you have an individual on rapamycin, over time, those cells gradually express PD1 and are eliminated, whereas if they're on a calcineurin inhibitor, they don't. So intuitively, with experience, we become more exhausted, more senescent, and less tolerant. That's not just an immunological fact, that's a social fact. And we can't adapt to what we can't see. Calcineurin inhibitors prevent us from seeing what we need to adapt to. Now, we can definitely eliminate memory cells if memory cells are the problem. But when we eliminate memory cells, it also eliminates memory against virus. And this is a nice paper also published by Denise Lowe, demonstrating that when you take out all the memory of an animal, that they don't reject their graft, but they also don't reject their viruses. Indeed, when you eliminate memory from a population, sometimes it is counter-adaptive. As was pointed out in this book, The Origins of Totalitarianism. Another somewhat political analogy, but intuitively you know that eliminating memory causes more harm than good. So, does this work in transplantation? Can we block co-stimulation to eliminate the context of inflammation and reduce the signals of amplification and augment and leave open the signals of specificity to lead for graft acceptance? The answer is yes. And there's an experiment that we started doing about 10 years ago with immunosuppression that was based on that. We used a single dose of alemtuzumab to minimize the size of the allo-specific immune response. We blocked co-stimulation. We added sirolimus instead of tacrolimus to allow the immune system to adapt over time. And in this first 20 patients in a trial that was sponsored by the FDA, we had a 0% allograft rejection rate and 100% graft survival in this first cohort. Importantly, as we followed these patients, we were able to show that over time, they gained cells that were co-stimulation sensitive, and they lost cells that were co-stimulation resistant. And so we went back and tried this again in another cohort of patients. And this is a paper that's just now been accepted this month in AJT. We found that many of these patients were able to be weaned to monotherapy belatacid, such that if you allow an individual to adapt over time, their requirement for immunosuppression reduces, not increases over time. In fact, as we follow the kidney function in these patients, the kidney function has improved with time in these patients because they're not on a calcineurin inhibitor and they're not undergoing a continuous need to prevent rejection. So to summarize, transplantation remains encumbered by its association with non-specific immunosuppression. But by conceptually focusing on context and magnitude instead of specificity, the risk of rejection can be reduced. A regimen of alemtuzumab induction, magnitude reduction, with belatacid and sirolimus prevents allograft rejection in kidney allograft recipients without having to use calcineurin inhibitors or without having to use steroids. The two drugs that were pointed out earlier in the lecture prevent co-stimulation blockade resistant therapies. The regimen appears to be tolerable, leaving a repertoire that is progressively more permissive for co-stimulation-based immunosuppression, and it allows some patients to transition to once-a-month single drug therapy. We now have over 5 years of follow-up on these patients. They have been receiving only belatacid as their drug once a month for now over 5 years. So conceptually, transplantation allows a foreign organ to save dying people. Clearly, in this case, foreign is not something that should be eschewed. Rejection can be prevented by blocking antigen engagement with a calcineurin inhibitor, but this also prevents adaptation and acceptance. And as soon as the blockade is gone, rejection ensues. So tolerance is achieved through engagement with the antigen without all the contextual signs of inflammation and with control of the amplitude of the residual cytotoxic effectors. Now, initially, this approach is metastable and it has to be maintained. But if you continue to focus on recognition and blockade of co-stimulation, over time, new antigens presented in this beneficial context without the fuel of inflammation eventually exhaust the remnant harmful memories. And tolerance becomes increasingly stable over time, requiring less intervention. So after 20 years of studying this, these are my conclusions. Not everything that is foreign is harmful. We exist through an inherent attraction of difference. Benefit and risk are not based on specificity, they're based on context. Inflammation fuels an assumption of harm and drives reflex defensiveness. It's best to consider the context of your engagement. Even an appropriate response in the right context is wrong if the magnitude is inappropriate. The loudest is rarely the most adaptive. Tolerance takes action. It's inherently metastable, but it strengthens with time. Properly considered decisions become self-evident and don't need continuous enforcement. For every complex problem, there is a simple solution that, though it is simple and neat, it's wrong. Sometimes when we approach complex problems, the error is in focusing on specificity. Sometimes it's in having an overly inflammatory context. And sometimes it's just having a magnitude that is too loud. But most of the time, it's when we fail to remember that we exist because the forces that bring us together overcomes the energy that tears us apart. Thank you very much.
Thank you, Dr. Cook, for a remarkable and lucid presentation on tolerance that goes beyond the science and can also cover our social context. And I do appreciate the lucidity with which you presented. We do have a couple of questions for you, and these are not social questions. They're adhering to science. The first question is, do you feel there is a role of BCG or chronic intestinal parasites in reducing alloreactivity?
Yeah, there's no doubt that there is. We establish immune responses against our environment. That's just how we survive. And since every T cell has the innate capability for some level of alloreactivity, every time we establish an inflammatory response, we increase the likelihood that we're going to have an immune response to an alloantigen that's inflammatory. And every time we establish a tolerant response, it will increase the likelihood that we establish tolerance to an alloantigen. It's interesting that a lot of helminths, parasites, in certain communities, people that have developed tolerance to intestinal parasites have also developed a lot of tolerance to alloantigens as well. Those experiments have been, they're pretty old experiments, but they exist. I don't know that I would go giving people tapeworm to prevent them from rejecting an allograft, but the biology is still very valid.
Yeah, thank you. Now, many of our centers or programs were involved with the Bella studies, and I've had firsthand experience. And one of the guests made a comment that most Bella studies use only MMF and not mTOR inhibitors. What are your thoughts on that?
It's wrong. So, the problem with mTOR inhibitors is that they're just hard drugs to use. They have trouble with wound healing. They have issues with arthropathies and mouth ulcers. And so they're not really pleasant drugs to work with. But if you were really working on trying to establish the best environment for belatacept, that's the drug that in every experiment shows the synergy. So the approach that I have taken is to try to use an mTOR inhibitor and deal with the consequences of that, recognizing that the long-term benefits are much better than the short-term problems. Now, still, about 20% of the patients that I put on a de novo mTOR inhibitor can't tolerate it. But I would rather give 80% of people the right drug than 100% of people the wrong drug. And if I have to take people off of an mTOR inhibitor and use something else, like a calcineurin inhibitor or MMF, so be it. But I'd rather give them the best shot at getting the right drug first.
Great, thank you. Well, before I move to the next question, I'd like to read a couple of the comments made during your presentation. Excellent talk. Thank you for making the topic more comprehensible. Amazingly timely analogy on tolerance. Great scientist and thinker. And another comment before we move to the next question. Well thought out and textured and simplified lecture. So the next question is to you, if in the context of the protocol that you proposed, where do you feel the role of the DSAs in immune monitoring and the variety of techniques we have now with cell-free DNA, what role do they play in this type of protocol?
Well, I think that if you have a DSA, then you have already established memory to that antigen. And it points out that if you are going to try to use a co-stimulation blockade approach, it's not going to be nearly as effective in that space. So I would say for this type of regimen that you have to have very good pre-transplant typing. And even if it is a past positive that is now negative, it is still memory that's probably not going to work so well. So I think that the subset of people this works well for are people that have not established a pre-established immune response. I also think that when you see alloantibody creeping out, you have to recognize that it's not just a B cell response, it's a T cell response that led to that. And dealing with the T cell response is necessary to shut that down. There's some really nice studies being done by Stuart Connectley right now, looking at combining co-stimulation blockade with blocking proteasome inhibitors. And if you use a proteasome inhibitor, you can prevent the antibody secreting cells from replicating, and the co-stimulation blockade helps new cells from coming in and replacing them. And that as a means of desensitization looks like it will be quite useful. We're starting to do some protocols combining proteasome inhibitors like carfilzomib with belatacept to desensitize patients and return them to a naive state.
Yeah, very interesting. Thank you. There is a question whether context is the reason that an infection can break down a certain degree of tolerance and lead to increased risk of rejection.
Yeah, absolutely. So one of the first patients that we ever did this experiment in was an African-American male receiving a non-matched kidney. So he would be considered high risk. But we were able to treat him with this regimen, belatacept, rapamycin and Campath, he was able to wean down to monotherapy belatacet and actually wean off of all immunosuppression. And he was off all drug for almost a year until he got the flu. And when he got the flu, he spun up an immune response. And since he didn't have any drug on board to prevent a new response against his graft, he had a rejection. So it's like I said, every time you have an immune response to anything, it changes your immune response to everything. And so probably having some context blockade in the background, even for people that are doing well, is a good idea.
Great, thank you. One more question. Let's see. In Asia and South America, for liver and kidney transplant, ivermectin is given routinely prior to transplant without good science. Are we adding to alloreactivity? I'm not sure what ivermectin is.
Yeah, it's an anti-parasitic drug. And so the question is whether if you disrupt the relationship you have with parasites, are you going to do all better or worse? And I guess it depends on what type of immunosuppression you're using. If you're using a calcineurin inhibitor, you're in trouble if you don't get rid of the parasites, because those parasites will be able to take over. If you're using co-stimulation blockade, it's not clear that you need to do that because you've already established memory against the parasite. And really all you're trying to do is prevent a new immune response against the allograft. So, I could see that practice going different ways depending on having different drugs.
Yeah, thank you. Another question, would you give some T-cell depleting therapies for AMR with de novo DSAs?
Yes. I think if you have de novo DSA, some T-cell depleting strategy is usually warranted.
Now, you're from the school that believes that a lot of the AMRs we deal with are T-cell based, and really we should not be chasing our tail per se, but going after the T-cells and dealing with some of the depletion, right?
Yeah, and sometimes you'll have an AMR that it looks like it has no cells involved in it. And what really is happening there is that the cells are helper cells and they're facilitating the antibody response. They just have had their cytotoxic T cell response blocked adequately. So your CD8 response doesn't work very well, but your helper effects are driving your B cell response. But at the core of that is still a CD4 T cell response.
Yeah, thank you. So what do you do then with people who are undergoing retransplants or have a high donor antibodies, or we have what you call the specific alloreactivity to particular antigens? How would you approach them from an immunologic perspective, given your protocol? Do you do something different?
Well, first of all, the best thing to do is to avoid going into a mismatch, and you can avoid it through paired exchange. That's far and away better. If you cannot, in other words, somebody is 99.9% sensitized and they're just never going to get a graft, you need to try something, a desensitization strategy, but you can't assume that they have lost their memory. And so you're going to have to use a pretty heavy-handed approach to control the specificity. So in those individuals, a calcineurin inhibitor-based approach is required, and a pretty heavy-handed approach up front is required. If you can eliminate the alloantibody through desensitization and hope for accommodation later, that's the only way you can go. But the best thing to do is to avoid the cross match if at all possible.
Yeah, thank you. We have room for one final question. When will we get a true test to assess T cell function? Or maybe we can extend that. How do you test immune reactivity in the context of transplantation as you're describing it?
So, probably the test that is most likely to become usable is the ability to sequence the T cell repertoire. So now that genetic techniques are such that you can do single cell sequencing on an entire person's repertoire in about a day or two for, maybe $400 or $500. We now have the ability to determine the allo-responsive T cell receptors by doing an in vitro MLR and then sequencing the entire repertoire of the individual to see if they have an increase in those T cell receptor bearing cells or a decrease, and monitor by looking at sequencing analysis. Right now, that's not practical to do clinically, but as fast as the genetic techniques are moving, I would bet, 5 or 6 years from now, we're going to be able to follow people with single cell sequencing analysis and just be able to see whether they're increasing the T cell receptors that are specific for the donor or not. And once you can figure that out, you can figure out how to go in and individually eliminate those cells.
Yeah, great. Thank you much. Well, that ends our questions, and I want to thank you so much for making the time, for giving us a very lucid and comprehensive topic on tolerance, both in the medical and social context. We've had many comments in the chat box about your presentation, how people enjoyed it, and certainly a recognition for your contributions to the field. I want to thank you on behalf of our audience and the Henderford team for being our guest speaker, and we hope to see you again. Thank you so much.
It was my pleasure. Thank you for allowing me to speak and to participate in rounds this morning. I really look forward to being able to seeing you in person someday when that's possible. And until then, keep up the great work you're doing up there in all respects, and be safe.
Thank you very much.
Bye-bye.
Meeting adjourned. Thank you much. Have a good day, everyone.